Irene, GLP1 drugs.
Yes.
Webinar 1 for the year. Kicking off with a pretty hot topic at the moment. We're seeing a lot of referrals for GLP1 drugs at the moment with IMM.
Yeah.
Today we're obviously going to talk about GLP1 drugs in workers' comp and CTP personal insurance claims, more so than just in general public. However, there's obviously going to be a lot of information that correlates to just general patients, but we'll dive into a little bit about what it means from a case manager and insurer's perspective, how we help with independent med management in helping liability decisions around the treatment of medications like these, supporting weight loss treatments and all those sorts of things. And yeah, going to that after that around the medication itself, how it's used, why it's effective, why it's sometimes ineffective, and what it means to be effective even.
Exactly.
So we'll talk about that as we go. But I wanted to introduce myself. My name's Luke. I'm the Director of Independent Med Management. I'm also a pharmacist. Irene's one of our first pharmacists to join the business way back when. You've got a really good background. I really think your background in other pharmacy, oncology and things ties well into doing what we do at IMM with clinical resources, understanding clinical studies and all those sorts of things. So why don't you give me a little bit of a background as to like your history in pharmacy and then your experience with IMM.
Yeah, so I originally started off with community pharmacy, which I did for a while, but even whilst I was doing that, I still specialised in different areas. Like I worked in an Indigenous community in Darwin, so you're dealing with very specific medication regimes, patients with renal failure, things like that. And then I moved into clinical pharmacy where I worked in 2 different hospitals. I then specialised in IVF medicine and worked in an IVF clinic. And then I moved into oncology and haematology where we also conducted clinical trials. So I feel like when you're doing lots of clinical work, you definitely do need to understand how to read clinical evidence, how to
how to understand and interpret
it, correctly.
Yeah.
Instead of just reading the headline of a study, actually diving into the study and determining what it's really saying versus what they want you to think it says. And then how to use that in real life as well, because when you're dealing with patients and medications, all medications have risks. All medications have side effects. There is nothing without a consequence. How to manage that in a safe way for patients. So I do think that having all of that clinical knowledge and also the clinical trial background where you do a lot of studies and your report writing and things like that's really helped in the role at IMM because everything we do is so clinical. And we do get, for example, we get fireys who do have cancers and we do have to deal with oncological medications and we've got to deal with pain, we've got to deal with injuries and PTSD and all sorts of things. So all of that information is knowledge that we need to be able to do a complex report like this.
Yeah. And for it to be beneficial to the end user, whether that's the clinician, like the doctor or the specialist, even the patient, or whether it's beneficial to the insurer as well. So the language in our reports is very specific to the industry that we work in.
Yes.
I think.
Yeah, definitely.
So I'm going to dive into this, obviously GLP-1 drugs in workers' comp and personal injury claims, but I just wanted to give everybody a little bit of an understanding as to what we do at IMM, how we can support insurers and doctors and things around that. So we work exclusively in workers' comp and CTP claims across Australia. Fortunate enough now to be working with all major insurance companies in every state and territory. And we've recently updated our services as of the start of this year. So now we've diversified a little bit in what was previously a really comprehensive medico-legal and medication optimization plan in one huge report that was called a primary assessment. We've now separated them out to be a pharmacy review and a medication management service. So the intention is the pharmacy review helps insurers make liability decisions, identify risks, identify medications that people are on if they don't have that information in front of them. And then the med management side of things is where risks are either confirmed or perceived when it comes to medications and how we can help improve medication use, therefore improve outcomes for the patient, reduce adverse effects,
risks,
all those risks associated with it, and then therefore help them return to work or return to life faster. So the 2 services come with add-on services obviously as well, but I think for simplicity, check out the website. There's a lot more information on there now with a new revolutionised website for
Yes,
2026.
definitely.
So a lot more information on there that explains the differentiations between the
The two
services
reports.
and what can be added on as well.
Yeah,
So,
but even calling the office and speaking to one of our pharmacists would be able to break it down and do a little educational session.
Yeah.
And then that way it just makes it easier to understand how to refer moving forward.
yeah, for sure. And for anybody that's new and they want an education session for their teams, then you or I or Beth or any other pharmacist
Yeah,
can accommodate
can
that
do
as
that.
well, just to explain the services,
What
the
we
benefit,
do.
where their trigger points might be,
Yeah.
and all those sorts of things. But let's dive into it. So, independent med management, GLP1 drugs in workers' comp CTP.
Yep. Let's start with what they are. So it's been around for about, since 2020, I think, is when we first started to see GLP-1s, and the prescribing of them has just dramatically increased. So the first ever one that we saw was Saxenda. Not popular at all. You had to do daily injections, so that's really hard to comply with. But since these new ones have come out, Ozempic was the first one. Everyone knows Ozempic.
Yeah.
Everyone knows that one.
Yeah.
Originally, that was released as a diabetic treatment only.
Yeah.
So all the PBS criteria, all the indications for its use everywhere, and all the clinical documents was only used for diabetes. But they found that as a side effect of this GLP-1, it was helping weight gain as well.
Yeah.
And the benefit, once weekly injections.
Yeah.
So immediately think people who were on Saxenda are going to transfer to Ozempic, but I think the Ozempic thing just went crazy and everyone went on it for weight loss.
There was so much publicity around it with like influencers and celebrities and things using it. And I remember
Yes.
like we were looking at one where it was like product placement in whatever TV show it was, but like somebody opened a fridge, like a Kardashian or someone opened the fridge and here was like a box of Saxenda, of Ozempic.
Of the Ozempic.
And you're like, oh my God, this is blowing up.
And it really has.
Yeah.
So I did some research on the biggest profitable drugs globally.
Yeah.
Like just
all GLPs.
And they were number 2. So number 1 was pembrolizumab, which is an oncology drug, which they use for numerous different types of cancers. And that made $30 billion profit. And number 2 was the GLP-1s, Ozempic, semaglutide, which is the drug name.
Yeah.
And that was like $15 to $20 billion.
Yeah.
So the second most profitable drug of our time. That's how much that this has gone crazy.
Yeah.
Everyone wants a quick fix.
Yeah.
And these GLP-1s do work. So following Ozempic, Wegovy came out, and that one there is actually approved for weight management. But since that happened, the Ozempic rules changed. So it's not just diabetes anymore.
Yeah, because what happened was once one GLP-1 drug got the approval for weight loss, everyone else, every other manufacturer went, if they can do it, we can do it. We'll do the trials.
Exactly. And it's the same drug. Both Ozempic and Wegovy are semaglutide.
Yeah.
So you
Yeah,
can't...
so what's the difference? It's
the doses.
Yeah.
And that's basically it. It's just that Ozempic first came out, was patented like essentially for the diabetes. Wegovy came out much later. It has higher doses that you can increment to, and it was approved for weight management, and so that's really the difference. Then you got another new one called Mounjaro, which a lot of patients are on. Clinical evidence shows that one seems to be a little bit better for weight loss outcomes than the semaglutide, and it also has the same sort of thing of the dose escalation to really high doses, but it is a different drug to the Ozempic and Wegovy.
Yeah. So you're saying they work?
Yeah.
Yeah.
They work. So I wanted to go through the weight management because I think this is really important. So these are the actual indications and the guidelines for prescribing a GLP-1 for weight management. So you have to have a BMI of at least 30.
Right.
Or if it's less than 30, you have to have some other condition. Maybe you've got diabetes or you've got really bad hypertension, but some sort of risk factor.
So other chronic diseases that correlate with it.
Yeah, exactly.
Yeah.
Because then the weight loss is going to improve those chronic diseases, cardiovascular outcomes, things like that. But the most important thing, which I feel like needs to be really addressed during our discussion today, is that the GLP-1s have to be used as an adjunct to lifestyle changes. And the obvious lifestyle changes are diet and exercise.
Yeah.
And I think that's really important when we're talking about patients with injuries, because exercise obviously is going to be an issue depending on what the injury is. And diet may be an issue depending on what the injury is too, because
I think especially in the space that we're in, where it's most likely a physical injury that's causing immobility, therefore weight gain.
Correct.
Or medication adverse effects that they're attributing weight gain to.
Yep. Or psychological symptoms contributing to binge eating, and then that's leading to weight gain.
Yeah. So that's the sort of area that we see weight being accepted by an insurer.
That's right.
Which emphasizes the secondary, like, diet impact on that person, because if they can't exercise, then there's more of an emphasis on their diet to manage weight. And then if they're taking medications, that may increase appetite or may increase their want for more calories, or sometimes even just changing the body's mechanisms of retaining weight emphasizes the need for a calorie restriction or a net even calorie intake.
But even not discussing calories, what is the diet itself? Is it a healthy diet?
Yeah.
Or because of an injury or a psychological condition, are people reaching for quick fast food options, which are also going to be impactful on weight?
Yeah.
So dietary education is massive.
Yeah.
It's a massive component.
Okay, so BMI of greater than 30 or 27 with comorbidities.
Correct.
Okay.
The other one is sleep apnea, which is a new indication only for Mounjaro, because a lot of sleep apnea is not all of it, but a lot of it is because of weight gain.
Yeah.
So that's another new one as well.
There's so many new indications and things coming out.
Cardiovascular is going to be another one.
Totally.
Yeah.
And the correlation's kind of there when it comes to weight management, but it's more about whether weight management needs to be addressed pharmacologically first, or whether there's other things that can be done first.
Yeah.
Is a lot of the cases. But
yeah,
and
I agree.
Now that there's GLP-1 drugs around, doctors are less inclined to prescribe things like we had Duramine and things in the past. They're not going down that pathway. They're just going straight to these drugs.
It's because they do work.
Yeah, and
they do.
There's significant side effects that come with phentermine anyway.
Yeah, with a minimal... I actually have some stats here that we can go through. So basically this is why it has blown up so much. This is so far the most effective pharmacological treatment for weight loss that we've seen. Because the first ever one, I don't know if you remember Xenical that we used to sell at the pharmacies. Basically that was supposed to stop you from absorbing fat and then you were excreting the fat. But that also came from this old knowledge thinking that fat was a contributor to weight gain, which there's a lot of new evidence around that not necessarily being the case now. But it had about a 3% efficacy. Nothing. 5% at the most if people are dieting really well and taking the Xenical. Horrible side effects.
Yep.
Then we saw the Duramine. So that's what you were saying before, the phentermine.
Yep.
Much better efficacy. Essentially, it's increasing your metabolism. It's giving you more energy so you can exercise more. It's also suppressing your appetite. And that's got about a 5 to 10% weight loss, which so better.
Yeah.
But people can become dependent on it.
Totally.
Yeah. Because
it was the drug that they were saying the housewives used it back in the day, and then the husbands would come home from work and the house would be spotless clean, and they're just like high energy, everything's
exactly
the cleaning drug. They'd be up all night cleaning
and you feel good.
Yeah,
because that is one of the it's a stimulant,
speed almost,
essentially. And so it makes you feel good, you feel energetic, you're doing really well. It's almost got that little bit of like mood elevation. And so dependence was an issue. And so that's a barrier. Then we got the new version of Contrave, which it hasn't really picked up as much as I thought it would, even though the stats for it are similar to the phentermine. But it's also an antidepressant mixed with naltrexone, and that's supposed to be quite helpful for weight loss. About a 10% weight loss can be seen with that in clinical trials, but not really popular. The cost it's expensive, not expensive. It's like in between. But
GLP-1 drugs are pretty expensive.
Oh,
as well.
They're so expensive.
Especially for insurers where they're getting charged 2, 3, 4 times
more than what they should.
Be,
So to compare the 10%, 5% weight losses with those drugs, these GLP-1s, you're looking at 16% with the Ozempic, Wegovy, up to 22% of body weight loss with the Mounjaro.
Yeah.
So look, the evidence is there.
Yeah.
Like we know that.
Yeah.
It is working. People are prescribing it left and center. It's a quick fix solution. It's easy. Doctor just writes the script. Here you go. Thanks very much. See you later.
Yeah. Yeah, and I think that's part of the problem as well, is that the overall management of weight seems to be poorly managed from a GP's perspective, where we almost need to have the involvement of a dietitian or at least some dietary advice along the way
100%.
if they're starting these sorts of drugs. And unfortunately, a lot of the drug companies are the educators to the doctors for these sorts of things as well. So their intention is to have these patients prescribe these drugs lifelong.
Yeah.
Not for a 12-week trial period or for a 12-week initiation period where these is to assist with the initial weight loss. Then once you've lost 5-10% of your body weight,
Yeah.
then we can stop the drug. Hopefully
What's the
other
exit
changes
strategy?
that you've done
Yeah.
improving along the way.
Exactly.
And that's actually the thing that's going to have the long-term effects. But give us a reality check.
All right, reality check. So these stats are really interesting. So about 50% of patients prescribed any form of GLP-1 are going to get a side effect. And we're going to go through into detail about what all the different side effects and risks are with the GLP-1s. But that's half of patients, quite a lot.
Yeah.
22% actually have a nutritional deficiency, and that's within 6 to 12 months of use. So it's not long. So 6 months in, 13% of patients had a diagnosed nutritional deficiency.
This is because and I think you go through this a little bit later anyway, but a lot of the reasons people are losing weight from these drugs is they're not taking on the nutrition.
Exactly.
They're significantly calorie deficient.
The appetite's
deficit,
suppressed,
but
so you're not wanting to eat as much.
Yeah.
But the other part of it is we need to always go back to the diet, because if you're not eating a proper diet before, and that's led to the weight gain, and now you're continuing to not eat a proper diet now, even though you're losing weight, you're not going to be getting the right nutritional input.
Yeah.
And so that dietary management of making sure the fruits, the vegetables, the proteins, everything like that, to prevent this nutritional deficiency is so important.
Yeah.
But as you can see with my stat, 20% of patients prescribed a GLP-1 actually receive a structured educational component by the GP. 20% to discuss diet.
Yeah.
So no wonder that patients are getting these side effects, because it's just not being spoken about. And as a result, the next stat there, 80% of people are not going to adhere to lifestyle changes.
Yeah.
They're not being told about it.
We live in a quick fix society, for
100%.
sure. And we see this with pain, psych, weight now as well, where if there's a drug out there that can stop me from feeling hungry, I don't have to go through this mental heartache of not going to the fridge when I'm hungry or eating a better choice option.
Yeah, meal planning, cooking.
Totally. It's a challenge,
for
sure. And I think that's half the reason, probably 80% of the reason why people are going down the drug pathway rather than just the lifestyle changes first.
Exactly. And so the consequence of this, the other part of the GLP-1s is a lot of the weight loss that's seen. So up to 40% of patients experience loss in muscle mass as well.
Yeah.
And that's a dietary component and exercise component factor too. So these are the consequences of not having your lifestyle modifications implemented during the treatment.
Yeah. Emphasizes the protein intake. So as part of that diet lifestyle change, the lifestyle is resistance training, so increasing your muscle mass.
Correct.
Or at least trying to maintain or not lose the muscle mass.
Yes. Yeah.
And which is the same reason why they encourage so much more protein intake through this time, because you're already calorie deficient or in a calorie deficit. The calories that you're intaking has to be a high percentage of that being protein.
Yeah.
Otherwise
and
you end up
appropriate nutrients.
Yeah.
And then if you're not, so if you're like the 80% of people not doing those lifestyle changes, then you're going to be a part of the 99% who put on the weight again.
Yeah.
After they've stopped it.
Yeah. Yeah, so basically everybody that stops treatment does regain some level of weight.
99%.
Yeah.
It's inevitable. You might put on 5 kilos. If you lost 50 kilos, you might put on 10.
Right.
It depends. And also depends on your diet and lifestyle that you've implemented after. Some patients, by 18 months of stopping a GLP-1, put all the weight back on.
Right. Yeah. So that's why there's this big emphasis that the drug treatment's lifelong.
Exactly. Yeah, that's definitely what they're wanting to do.
Yeah.
So I wanted to go through the risks, because can you use a GLP-1 lifelong? Essentially...
Well, I guess the reality is you probably can. As in, the doctors will be...
The doctors will want to.
Yeah.
And this is the issue that we're starting to see now. Patients have lost their goal weight.
Yeah.
Great. They've had improvement in pain, improvement in mood. We do see that. Improved functioning.
Yeah.
They can exercise now. So, of course, it makes sense that no one wants them to put the weight back on.
Yeah. Yeah.
But using it for lifelong, we have never seen that actually happen in real life yet. So we don't really know what the long-term risks are going to be. And so far from the information we'll see here that there are some risks already. So one of those is gastrointestinal. I actually legitimately had a claim where a patient experienced pancreatitis from the GLP-1 and had to go in hospital for treatment for that.
Yeah, so while we're on that, if an insurer accepted liability for the weight, and therefore they're accepting the liability for the drug that's being used to treat that weight, and that drug now goes on to cause adverse effects like pancreatitis, they therefore by default accept that condition also, which is the thing that they need to consider when they are approving these types of treatments. Is the risk outweighing the benefit of using the drug? And is the risk outweighing the cost for the insurer, knowing that there are significant risks associated with these types of drugs and other drugs, but
all drugs. Yeah, but in particular, nausea, vomiting, you can handle that. But what's going to happen? Extra prescriptions. Yeah. There's so many patients. So many patients who are being prescribed the GLP-1 now and the antiemetic treatments as well, and that's continued ongoing.
Yeah.
Then you may have other consequences like the dumping syndrome, gastroparesis. Some patients that doesn't resolve after they stop the GLP-1. It's a small percentage, like 2%, but it's still there. Yeah. If they're on a claim, then, you may have to be liable for that condition forever.
And these are very, like the GI issues are very common.
But,
almost everybody taking GLP-1 drugs are having
50%.
Nausea. Nausea, vomiting, diarrhea, those types of...
Leading to that cascade of extra prescribing, extra doctor visits, in that case of the pancreatitis, hospitalization, time off work if they are working. And then dehydration is a huge risk, and there's a major risk of renal kidney injury, which is not good.
Yeah.
So it's definitely this issue of, okay, we're using one thing, but it's leading to all these other negative consequences.
Yeah, totally. And a lot of the times the nausea, vomiting, and this is somewhat anecdotal, but I've spoken to a lot of people that are taking GLP-1 drugs because it's so common now.
Yeah.
And a lot of the reasons they're not eating food is because they don't feel like eating, because they're actually feeling nauseous.
Sick.
Yeah. So that's not a beneficial thing for the drug.
It's not healthy.
No.
Like you need to, because what happens when you stop and you're not nauseous anymore and you're like, I can eat again. Obviously the weight gain. Yeah. Totally. It's not ideal. It's not the ideal way to manage weight anyway. This one here is something you're very passionate about.
Oh, yeah. Yeah, musculoskeletal risk is a huge one when it comes to weight loss, rapid weight loss, with therefore reduced muscle mass. And especially because we're talking about it from the context of a person undergoing active rehabilitation from a physical injury, or even limiting their exercise ability if they've got a psychological claim, because we know that movement, exercise, all those sorts of things has a beneficial effect on the psych condition, even if it's not a physical condition. So if a person is losing weight quickly and they're losing a larger percentage than they normally would of muscle mass if they were just going through a restricted calorie diet, that has a significant negative impact on their ability to recover.
Yeah,
and I think you talk more about this as well with respect to bone density loss, muscle wastage loss. If the intention for this person is to lose weight so they can function better, but they're losing weight and they're losing their ability to function because of the muscle loss, it's counterintuitive.
It is.
Not to mention that if they're also losing muscle mass and bone density, and then they stop the treatment and the person puts on weight, and sometimes puts on more weight than what their baseline was.
Yes.
Now they don't even have the muscle strength or the bone density to support that weight.
Exactly.
This medication's actually been a huge detriment to them in their ability to recover long term.
100%. And that's the thing. There's no such thing as a quick fix solution. Yeah, okay, you might have lost the weight, but what were the consequences of that?
Yeah.
And then, like you said, putting all that weight back on and all that extra stress when you've got less bone density and muscle mass is terrible for your cardiovascular, your glycemic control, the strength of your body. Your ability to engage in exercise is going to be so much harder. You're starting from scratch all over again to try and build that muscle back up to just what it was before.
Yeah.
Not even to be strong. It's just to get back to where you were baseline. Yeah. So what does that result for the insurer as well in a long term?
The challenge, I think, for the insurers is that, especially now where there's the clinical indication for these drugs, it's harder for them to say, no, it's not appropriate, or 100%. No, it's not reasonable and necessary, because it's got a clinical indication and the doctor's saying it is appropriate for this person.
Yeah.
Whereas it's these types of scenarios where it's, hang on, it might be claim related. The doctor might be saying it's claim related, but in our perspective, is it reasonable and necessary for this person based on their situation? Yes, it needs to be case specific. Can't necessarily be like a blanket rule, no, we're not treating it.
No.
Or not supporting it, but I guess these needs to be considered when they are considering funding these types of treatments. Is it going to be beneficial long term, or are they actually just kicking the stone down the road a little bit where now they're going to be liable for osteoporosis or the muscle wastage and immobility and all those sorts of things.
That's right.
Down the line.
Yeah. And then what can be done to prevent that? Obviously the most important thing would be exercise. Physio would be really helpful.
Totally.
General physio, hydrotherapy.
I even think just being upfront with the patient when they're prescribing it to say, hey,
Yes.
we're going to do this for 6 to 12 weeks to see whether it's effective. If it is, maybe we'll do it for 6 months. But explaining to the patient, like you said, was it 20% of patients are actually getting the right information at the time? So if you said, oh, okay, if we're supporting this treatment, we're only supporting it as adjuvant to those other things.
Which is the indication if we go back to the start.
Yeah.
That's supposed to be the case. It should be as an adjunct to those allied therapies
and the exit strategy should be
support.
discussed before starting treatment.
Yes.
As with almost every drug that's supposed to be used short term, that's a conversation that needs to be had with the patient up front. So as they know that in 12 weeks' time or 6 months' time, we're going to be stopping the treatment.
Yeah.
And that's great. You'll have lost some weight during that period. Yes, you might regain a little bit of it, but what the intention is, those other changes that you've made in your life are the things that are going to continue for you to lose weight in a healthy way that doesn't impact on bone density and weight loss and things. Yeah, the exit strategy up front, I think, is the
most important. And a plan,
yeah.
Like a really formal plan to make sure that all those lifestyle things are being implemented alongside.
Yeah.
Another thing, yeah.
Did you see the post that I put up?
Yes,
the LinkedIn link?
I know, yeah.
AI is so good. It's a real thing. The Ozempic
it's 100% a real thing. You can tell from a mile away who's been on Ozempic and has lost the weight.
Yeah.
You really see it in the face. You lost a lot of the fat distribution, and that's not just in the face, it's all over the body.
Yeah.
And even some people are also discussing the fact that fat loss occurs in intimate areas as well, and then surgical procedures are being done for things like that, or for sagging skin, saggy arm.
Skin.
Yeah. Fillers in the face to bring the skin back up. Like you said before, at what point is the insurer liable for these secondary side effects to the medication and the treatment?
Yeah, especially if they haven't been discussed or documented up front, I think is the big one.
Like, what do you think would happen in this case if a patient had excess skin because of this rapid weight loss?
It almost depends what insurer, unfortunately. But it does. Some insurers will just fund it, or the person will kick up a stink, it'll go to the PIC and they'll get it overturned, and then the insurer is liable for surgery for excess skin loss and all those sorts of things as well. But
it's something to consider. Like, it is a thing.
Emotional impact's a big one, and I want to talk about that a little bit more because you've got it here. Do we talk about
mental health in the next? It's the next slide. We can go into it.
But yeah, the Ozempic pace is real. The weight loss, the fat loss, and bone structure and things change in the people's face.
There are some mental health impacts in patients who are using the GLP-1s. So there's two things I wanted to talk about with the mental health component. One thing is side effects. So the GLP-1 itself actually has reported side effects. So there's a study here that basically it'll double your risk of major depression symptoms and anxiety. Yep. And this is in the journal called Nature. So this is a proper published study.
Yep.
So that's a side effect of its use. But on the other flip side, if you're not getting those side effects, we're actually starting to see patients who are starting to develop eating disorders with the use of GLP-1. Or maybe there was an underlying eating disorder there that was never really diagnosed or noticed, and then the GLP-1
answers it all.
So that's another issue. The FDA itself had recorded more than 500 mental health reports since 2023, so that's in 3 years. I'm sure it's escalated a lot.
Yeah. To push back against that a little bit, the use has gone so crazy that you would expect that. And so when it comes to peer-reviewed journals and reported adverse effects and things, as a percentage, it's still a common side effect, but it needs to be reported at that as a percentage because of the increased volume of use. But it's still a huge concern. I think any kind of psychological stuff is, and especially when we start seeing it in our space where it's being used to treat a physical immobility and weight gain is associated with that, and pain and all those sorts of things, the development of psychological conditions as a secondary condition from that is what the insurers really need to be starting to pay attention to.
Yeah.
Especially when it's suicidal ideation, it's
That's
major
the risky
depression,
stuff.
it's insomnia,
Anxiety.
and all those sorts of things. Now an eating disorder.
Yeah. I
Like-
think it really, in this instance, for mental health impacts, it needs to be case by case. If you've got a patient who has had a physical injury, they've put on weight because of that, their mental health is really good, they go to psychology, everything's great, they lose the weight, they're going to see improvements.
Yeah.
They're probably not going to go decline in their mental health.
Yeah.
But if it's a psychological injury where they're binge eating to help deal with their emotions, they haven't dealt with their emotions, they're not engaging in psychology the way they're meant to, they get on a GLP-1 to lose weight, those issues are still there.
Yeah.
If anything, they might worsen.
Yeah.
That's my concern.
Yeah. I put a post up the other day around like the $7 medication escalation. So you could be prescribed, say, an opioid or a benzo for a long period of time, even if it's low dose, and that has an impact on your hormone levels, for instance. Yes, they're addictive and dependent, all that sorts of things, but say it impacts on your hormones, therefore you're sleeping poorly. That impacts your hormones even more. There's evidence now to show that if you have poor sleep, you binge eat or you eat more calories the following day
because you need
to
the
compensate,
energy,
right?
yeah.
So then you're gaining more weight, you're having calories in. That impacts on your hormones even more. So then there's this cascade then that just this $7 medication before has now impacted so much on hormones, sleep, now mental health, now weight gain. Now, if you don't start to deal with those sorts of things, it starts to create cardiovascular issues. This flow-on effect that no one's looking at this, what's caused this. And literally all it was this medication that was intended for short-term use back here has now cascaded into this massive cumulative effect of like multiple chronic diseases. It's actually so easy to just deal with this situation earlier than go down this pathway like later
where
on.
there can be long term.
Anyway, we digress. Sorry about that.
No, that's good. It's good information because it is relevant to all drugs. So what are the consequences of regaining the weight? So we did discuss that a little bit, but basically the muscle wastage is going to amplify the harm of the weight regain.
Yeah.
And also the bone effects as well.
So the person, you might regain back to the same baseline weight that you had.
That's right.
But now you don't have the muscle density to burn the
protect
calories, and you don't have the bone density to
Yeah.
to carry the weight.
100%.
Significantly worse situation.
And so your increased frailty risk. So what does that mean? It means maybe you're at increased risk of falls, fractures, breaks. Maybe you're way more susceptible to medication side effects as well.
Yeah.
Impacts on pain. Like that weight regain, when you've lost muscle mass and bone density, is the pain is going to feel more than what it did before because you don't have those protective barriers. It's going to have even further negative consequences to your cardiovascular health because you've really worsened your overall condition. And it's not going to have a long-term benefit in that scenario.
Yeah, so basically what you're saying is that the overall long-term benefit doesn't really outweigh the risks associated with
if it's not being done
use.
properly.
Yeah.
That's
and
absolutely.
and like you said, 20%.
20%.
So 80% of them aren't being done properly.
Exactly. Yeah, which is sad.
Yeah.
But it happens. So the overall question really is who's going to be liable for all of these long-term consequences for patients.
Especially if there's not been a line drawn in the sand like early on in the claim.
Yes.
Which is what we talk about with having an opinion, having the agreements from doctors, having the management plan put in place prior to all of these sorts of things, because now we would know, was weight pre-existing? Was it not? Is it directly associated with the claim? Is the treatment being appropriately managed?
100%.
Is it effective to start with?
Yes.
And then what's the exit plan after that? Because we know that they shouldn't be used long term.
That's right.
IMM's obviously there to support those decisions, I believe, as early as possible in the claim.
Yes.
And if you can have that sort of medication awareness, knowledge report in your system prior to that 12 months post-injury, then all of those sorts of things are documented.
Yes.
What was pre-existing? What was the weight at the time of the injury or previous
That's
to?
a big
what is
one.
It now? All those
There's
sorts of
so many that we do reviews for where the injury happened. I literally got one where the injury happened in 1987. I was born in 1987. That's how old that is.
You're
no
old.
one, no.
I'm older.
But no one person had a pre-injury weight. Obviously, it's so old.
Yeah.
And so then it's just this like guessing game of, 40 years ago, this guy was this many kilos.
Also probably going to the gym, playing football,
But
working as
40
a tradie.
years.
Yeah, that's right. They were 20 years old.
Come on.
fit.
Like,
Yeah.
how do you know he wasn't going to put on weight anyway? Like,
Exactly.
age is a factor. Just general lifestyle. Like, even if the injury never happened, how do you know he wasn't going to put on the weight?
Yeah.
Like, you can't really determine that. I think that's really hard when it's like a seriously old claim like that.
Yeah.
But even new claims, one where a patient had an injury in 2020, no recorded weight. The doctor didn't have a weight, because often patients who start a claim go see some new doctor who's never had that information.
That's right.
And then the insurers never thought to gather that data at the beginning. So now it's another guessing game. They said to me that they were about this much at that time and they've put on 30 kilos. I don't have proof of that.
Yeah.
There's no evidence for that.
Yeah.
So getting involved in these claims earlier can finalize all that proof from the get-go. So if there is a discussion of weight gain later, we have the evidence. Yeah.
Totally agree. Yeah, secondary liability is a huge one, especially when we start talking about that cascade of events like the hormone issues, the sleep issues, the psychological conditions, the suicidal ideations, the hospital admissions associated with that. Like, just doing this service up front could save $50,000, $60,000, $100,000 worth of liability issues 3-5 years down the track.
Exactly. What is the future of GLP-1s? We've said it, but all the clinical studies now are all about trying to push lifelong use for these GLP-1s.
Yeah, and I think, is it 72 weeks or something, which is like some of the trials?
Some of them are even
associated with-
over 2 years now.
Yeah, right.
104 weeks.
Yeah.
The new ones, these are phase 3 trials.
Yeah.
And they're literally doing the trials for maintenance.
Yeah.
So they're saying, oh yeah, we know patients are going to put weight on when they stop these drugs, and so therefore they have to just stay on them for forever.
Yeah, and from a pharmacist's perspective, or from an IMM's pharmacist's perspective, it's like these drugs are indicated for weight loss, not for the prevention of weight regain.
Yeah.
So lifelong treatment isn't an appropriate strategy, I don't think, for the management of
Pharmacologically.
these things. Yeah.
Yeah.
Pharmacologically.
I think that the way that these can safely be used is the implementation of diet and lifestyle exercise modifications, and that is what's used as your maintenance to maintain the weight.
But look, it's the same with every treatment that we talk about. We talk about pain, for instance, and one specialist that I spoke to back in my medical repping days was that pain medications shouldn't be called painkillers, they should be called exercise enhancers, because it's actually the management of pain that improves their ability to exercise and function. And that's actually the thing that's having the long-term effects of pain management. It's the same with these. This should be used to kickstart potentially for those difficult cases, and then discontinued, and it's the lifestyle changes that have been implemented and the habit formation that's been implemented through that period.
And if it's used appropriately, education, diet, exercise, all of that stuff, patients lose weight, you do see an improvement in pain. Reduce the pain meds. If they've been on high dose opioids before, now their pain's improved, they've got weight loss, it's not impacting their knee joint as much and the knee injury is improved, reduce the opioids, reduce the high risk drugs.
Yeah.
Actually implement those changes, because that's another thing that we're always discussing. Oh, they're having great mental health is amazing, excellent. Let's reduce the benzodiazepine that's there for anxiety.
Yeah.
They don't need it anymore. Let's really make some improvements for this patient.
Yeah.
So that's another thing, but it needs to be done appropriately, and it needs to be with a doctor who's willing to really engage with that patient in an educational way to make those improvements. Yeah.
Totally.
But the other new thing, which I thought was really interesting, because I do think that this will blow up as soon as it comes to Australia, is the GLP-1s in an oral form.
Yeah.
So it's already happened. It's here.
You'd think that the injections would be a barrier to use for the big pharma companies.
Now, it probably is for some people. But
it shows now, though, that people are more willing to go through that, like, perceived or not perceived, it would be uncomfortable to inject
once a week,
once a day, whatever the case may be.
Yeah.
And it hasn't shown to be that much of an impact for people
They're still
adopting this
doing
treatment.
it.
Now, if there's an oral formulation, it'd be
Even
like whole
easier.
populations on it. It'll be like
Literally.
the statin back in the day.
Yeah.
Where if you're even slightly overweight, you should take
Here,
this
just take the oral if you're
formulation.
scared of injecting.
Yeah.
And so it's already been released. It's available in the US as of the beginning of this year. An oral GLP-1 is called Rybelsus.
Yeah.
It's the same drug as what's inside the Ozempic.
I think some people are getting black market ones in Australia already.
Probably. But
I've
this
heard
is
of that.
only approved by the FDA for diabetes, same as what Ozempic was back in the
To
day.
start with.
But everyone's
It's their
using
entry
it
into
for
the
weight
market
loss.
though, really.
Yeah. They just get whatever approval they can to get it on.
Yeah.
And then everyone just prescribes it for weight loss. And it's working. There is GI side effects, and obviously because it's being used orally, then those side effects are probably more experienced than what the injectables are.
True.
But the clinical data so there's a different drug that they're going to get ready to release towards the end of this year called orforglipron. Don't know how to say it. No. Phase 3 trials.
So it's another GLP1
Another
drug,
oral.
Yeah.
Another oral. Yeah, phase 3 trials at the moment. Weight loss at 72 weeks of up to 15%. So that's pretty good.
How long?
72 weeks.
Right.
And that's due for FDA approval late this year for weight. And basically what's happening is that first drug will piggyback off of those trials and it'll come out as body weight loss and stuff like that. So oral GLP-1s are coming. Absolutely. It won't be long for Australia. And I think we'll see a massive uptake of that. Massive. Yeah.
Very good. All right, let's wrap it up. Before funding GLP-1 drugs, we strongly encourage a pharmacy review.
100%.
It's the same as the cannabis thing. It's as expensive, if not sometimes more expensive, and it's more the management side of things that needs to be documented and discussed and
long-term plans
implemented first. Yeah, the long-term plans. So IMM pharmacy review to determine liability, whether the weight's associated, whether the treatment should be funded, what are the risks associated with it, all those sorts of things. If you are considering funding it, med management report would be the beneficial thing to do, where we can document and discuss the medication management strategies with all of the prescribing doctors. Make sure that there is an exit plan put in place, because if you're not doing that prior to funding and the funding's not a conditional approval, then it's most likely you are going to be funding these treatments lifelong, and that's going to have those snowball effects for those other conditions that you'll also be liable for down the line. So check out our website. We've got new services and new information around our services on the website. The referral form has also been updated. Very secure, safe, online referral straight through to our system with file upload documentation capabilities. And there's also a contact us page. So if you need anything, obviously you said that at the start, we've got pharmacists that work in the office every day. So there's always somebody here to answer some questions.
Absolutely.
Keep an eye out for the next webinar that's coming out, which is going to be on medicinal cannabis, which is another hot topic. And we will see you in the next one.